Good afternoon. Welcome to our Antibiotic Stewardship Echo for today. Troy Jorgensen, Program Manager.
Charlie Krasner.
Mike Stander.
Jessica Thompson.
Marshall Renner.
Esther Zane. Amy Smith.
Okay, well, if you have anything that comes to mind during the presentation, feel free to unmute yourself with that microphone icon in the lower left corner of the Zoom window, *6 if you're joined by phone, or using the chat box.
So maybe you can get the slides up. So we've been doing this since, for the new guys joining, it's great. We always like new blood here. We've been doing this since 2012, and basically we're trying to discuss problems that are common problems. We've done urinary tract infections, we've done C. diff up to wazoo, just about everything. And so we were asked to talk about Staph Aureus Bacteremia today. And I've been doing ID for about 25 years, and I think on my first cases, my first job, I heard about a patient. He was on surgical service. He had Staph Bacteremia, and they sent him home on oral clindamycin, and he came back about 2 weeks later with aortic valve endocarditis, and he died. And so that was my welcome to the business. Can you get these slides up?
Those are my
Oh,
Yeah, and I don't think this screen's working right now.
all right. Can you switch?
Yeah, so you just go to your share, and then the one right there, yeah.
Yeah, so
So just a quick reminder that we do record all these sessions, so if you don't want to be on video, let us know and we can edit you out. Amy, go ahead. Just a reminder also that if you present a patient case, make sure it's de-identified. We don't want any HIPAA violations here. So, all right.
anyway, so I'm a little unhappy that I have to use these new format because I'm very artistic with my slides. I take pride in them. Colorful. So anybody, this is the ECHO program, promote appropriate use of antibiotics to improve patient safety and outcomes. How to evaluate and treat Staph Aureus Bacteremia. And so I'm going to present a case, what we saw, unnamed hospital, and then I'm going to ask a bunch of questions, and then Jessica was going to go over the guidelines, and then we're going to come back and see if you can get go over the questions and see what your thoughts are. So this is a patient. Next one, please. So this is a 62-year-old guy. He came from a group home. He had electrolyte abnormalities and dehydration. Because of his neurologic condition, he was not able to adequately feed himself, and his electrolytes were out of whack. He was physically, he had difficulty speaking, but he had no bed sores. He did not have a Foley, and he was increasingly confused because of his mental condition and because his electrolytes were out of whack. So on admission, he was afebrile. There's no question that he had an illness at all. He had CBC, chest X-ray, and urinalysis were normal, and so they said we just got to correct his electrolyte abnormalities. He had a peripheral IV placed, and a feeding tube was inserted. And so what happened is that we had not seen the patient, but we were alerted there was a positive blood culture in this patient. So on hospital day 5, he had spiked the temperature, and the repeat chest X-ray, blood and urine cultures were obtained, and he was alert, but we walked down to see him, see what was going on and what the physicians were doing. Because this guy had been 5 days in the hospital with no problems, and also he had a positive blood culture and a temperature spike. Next picture. So this is a standard blood culture. So both his urine and his blood cultures grew what we call gram-positive coccidioid clusters. So you can see they look like grape-like clusters, and that's classic for staph, all different types of staph, Staph aureus, MRSA, but they look like grape-like clusters. And because they have a gram-positive cell wall, so the cell walls on the outside, they give you that purple appearance. So it's gram-positive because we know it's purple, and it's in clusters, and it's cocci. So just looking at that, we can tell it's most likely a staph infection. And because they didn't know what kind of staph it was, he was started on vancomycin, which covers all types of staph, Staph epi, Staph aureus, and MRSA. And so we went down and looked at him. Next slide, please. First of all, we want to know what the source of his infection. He had a clear chest x-ray, so it wasn't like he aspirated and had pneumonia. And his urine, which was sterile on emission, was now growing greater than 100,000 Staph aureus colonies. So this guy now had a positive urine culture growing a significant amount of Staph aureus. So we saw that already, and then we went downstairs and looked at the guy. Next picture. And so we examined the patient, as we do, and we looked at his right antecubital area, and maybe a little bit hard to see, but you can see a lot of redness, and you can see swelling in the area, and he had a exit site for his IV, and on exam you can feel a palpable vein. So he had definitely redness and abnormality at the side of his peripheral IV site. Okay, so these are questions that we're going to come back to after we hear from Jessica. So the question is the urinary tract infection the source of his bacteremia, since he went from sterile to positive? Does this patient require IV therapy for this Staph bacteremia? What additional tests are needed to evaluate this patient? How long does he need therapy? And when can a PICC line be placed? Okay, so we, as ID people and pharmacists, we see Staph bacteremia all the time. And for like the orthopedic guys, we definitely will see some Staph bacteremias, possibly from prosthetic joints and stuff like that. So these are the kind of questions you're going to ask when you see these patients. Is the urine the source? Does he need IV therapy? What additional testing will you want to do? How long does he need therapy? And when can a PICC line be placed? Next. And so we'll come back and talk about this a little bit more. So I'm going to hand this off to Jessica.
So one of the reason why we're talking about Staph aureus bacteremia today is because we were the majority of the things that we discuss here, and really just stewardship in general, is we're telling people to stop antibiotics, de-escalate antibiotics, IV to PO. We say no a lot. That's how we get the reputation of being the antibiotic police. Or Nazis, yeah. And I think that's a fair. The majority of ways that we optimize therapy is through de-escalation. Next slide. The exception, though, where it's more common that we're saying IV antibiotics only, treat for longer, do more tests. The exception is with Staph aureus bacteremia. This is one of the most common, it's commonly undertreated. The majority of infections out there, we commonly overtreat. Staph aureus bacteremia is really the exception. We tend to undertreat it. So why is Staph aureus different? There are lots of reasons. Won't get into the nitty gritty, but it produces toxins. It can form biofilm, making it hard to eradicate. It likes to adhere to things. So once it enters in the blood, it can really go anywhere in the body. And then it really likes previously damaged areas. So somebody that has arthritis, they can develop deceptive joints. It can seed the spine, epidural abscess, psoas abscess. Endocarditis is very common. And it's the most common cause of bloodstream infections from the community as well as in the hospital. And the reason why it's so common is for the virulent, the toxins, biofilm, and surface adhesins, and it colonizes up to 40% of the population. So about 1 in 2 people, a little less, are colonized with this on a regular basis. So it's everywhere. Next slide. Now, what are the complications? So once Staph aureus enters in the blood, there's this great study. This is, I think, from 2003, but any study since then has come out with very similar results. And this study looked at over 700 patients with at least 1 blood culture bottle positive with Staphylococcus aureus. Contrast that with coag-negative staph, like Staph epi. We really don't worry about it until you have probably 4 bottles positive, and even then it's questionable. With Staph aureus, if you have even one blood culture bottle positive, you have up to a 43 risk of complicated infection, which we'll elaborate on what a complicated infection is in just a minute, but common complications are endocarditis, septic arthritis, so on, and up to almost a 30% mortality associated with Staph aureus bacteremia. So this has a lot of or morbidity associated with it, as well as mortality. Complicated versus uncomplicated. This is important when we talk about the duration of treatment in the next several slides. There's really no formally agreed upon criteria. In general, when we're talking about uncomplicated Staph aureus bacteremia, we're talking about we've done our due diligence, ruled out endocarditis. We have no intravascular devices, no hardware at all in the body. We have quick defervescence, so afebrile within 72 hours. Our repeat blood cultures are negative. And we have done a thorough physical exam and workup to make sure there are no other metastatic sites of infection that need source control. So it's actually rare to have a truly uncomplicated Staph aureus bacteremia. The majority of cases are end up being complicated. Next slide. So there are no infectious diseases guidelines right now on the treatment of Staph aureus bacteremia. There's best practices out there. They're currently working on a guideline, but they're not available and published yet. There are MRSA guidelines, but no just Staph aureus in general. But most ID physicians will agree on these 5 points, which are summarized very nicely in this article, Essentials in the Management of Staph aureus Bloodstream Infections. And they have 5 points. Always consider Staph aureus in the blood as a clinically significant pathogen. You want to monitor repeat blood cultures every 24 to 48 hours until they're negative. You want to monitor your fever. Number 3, source control, source control, source control. 4, evaluate for endocarditis. And 5, treat for an appropriate duration of time. And so the next several slides are going to kind of go into a little bit more detail on each one of these points. So can Staph aureus be a contaminant? Yes, I mean, if 40% of the population is colonized with it, at some point it is going to be a contaminant. The reason why we don't treat it as a contaminant, because if you are wrong, the consequences of a Staph aureus bacteremia are completely devastating to the patient. The long-term consequences are absolutely, you don't want to miss it. So we err on the side of always treating a Staph aureus bacteremia. Hold on a second, let's see, yep, go ahead, sorry. It's important to repeat. So the point number 2, monitor length of bacteremia and fever. Why do we care about this? Well, for multiple reasons. 1, we actually start counting our duration of therapy from the first negative blood culture. So you would want to repeat blood cultures every 24 to 48 hours to ensure sterilization. You also, if you have repeat positive blood cultures, the likelihood that you have a source that you have not controlled is significantly higher. So if you continue to have positive blood cultures and you've already performed source control, you need to start looking again. It's already seeded another site. So in addition, lastly, also with the fever is another big indicator. You want to be afebrile at 72 hours. If you're not, start looking for other sources. Next. Source control is huge with infectious diseases. The antibiotics are just a supplement, and that same is true with Staph aureus bacteremia. And you can't just say, we have a bacteremia, we treat it as a bacteremia. All bacteremias have a source. You just have to find it. And it is rarely, if ever, the urine. There are a couple of exceptions to a Staph aureus bacteremia being the source. And that's if you have Staph aureus bacteremia being the source is urine. Unless they've had a Foley or some sort of urological procedure, then you have a reason for Staph aureus to be there and see the blood. But in general, Staph aureus doesn't have the ability to ascend the ureters. So if it's what you will see is a positive urine culture, but that's usually spillover from the blood. It's actually not a UTI causing a bacteremia. It's a bacteremia that has spillover into the urine, unless they have a reason to have, again, instrumentation or Foley. So you have to do a very thorough job to find the potential sources. You have to take an excellent history. Do you have chronic back pain that's now acute? Did you cut yourself recently? Are you an IV drug user? Then perform a thorough physical exam. Look for signs of folliculitis that may have disseminated. And then work up those sites. Order an MRI of the spine if you need to. Evaluate for an echo. Does the patient have a murmur? Because what we know is that if you have an unknown source, you have a higher 90-day mortality rate. Your mortality rate almost doubles from 25% to 46% if you're unable to find a source and control it if you don't do that immediately. Evaluate for endocarditis. This is separate because every single patient with a Staph Aureus Bacteremia, whether it be 1 blood culture positive or 4, should get at least a transthoracic echo. If the TTE is positive, you have your answer. There's endocarditis. If the TTE is negative, the majority of patients should also get a TEE. There are certain exceptions to this, but even that is relatively controversial. There was a survey recently in clinical infectious diseases that showed there's a little bit of a discrepancy between older infectious diseases physicians and younger infectious diseases physicians. I don't know, there's not necessarily a right answer, but younger infectious diseases physicians are more likely to get a TE in all patients with Staph Aureus Bacteremia if the TTE is negative. Older physicians tend to weigh the risk versus benefit. But why do we care so much about endocarditis is that up to 10% of Staph Aureus Bacteremia cases have endocarditis. So you actually have to go look for it. You may or may not hear a murmur in these cases. And if somebody's presenting from the community with Staph Aureus Bacteremia, that risk goes up to 20% having endocarditis. Duration of treatment. This is huge. The majority of people will tell you need at least 2 weeks of IV antibiotic therapy, and that's just for uncomplicated Staph Aureus Bacteremia. Again, as we mentioned earlier, more than half, or about half of cases are complicated Staph Aureus Bacteremia, and then your duration goes up to 4 to 6 weeks. Occasionally, we'll go 4 to 6 weeks if we have unable to identify a definitive source, even if they cleared the bacteremia quickly. This is one thing where most ID physicians will err on the longer side of treatment. This isn't E. coli bacteremia where we're cutting duration down to 7 days. Staph aureus is always 2 weeks, but more often than not, 4 to 6 weeks.
You just get a lot of pressure because a lot of our bacteremias are, the drug addicts from under the bridge, and the discharge planners want to get them out.
Yeah.
And then they're not going to send them out. So that could be a lot of pressure to want you to cut it short.
And the reason why we can't send them out is that the drugs of choice for Staph aureus are IV antibiotics. And for penicillins or MSSA, it's nafcillin, which is administered to 6 times a day, or Ancef. For MRSA, you're using vancomycin, which requires lots of monitoring. Please note, I didn't put it in here specifically, but vancomycin is inferior to nafcillin and Ancef for treatment of MSSA bacteremia. So if you have an MSSA bacteremia, you need to absolutely be using the drug of choice, nafcillin or Ancef. There have been multiple studies out showing that vanco is inferior, as well as other beta-lactams, other cephalosporins. You want to use nafcillin or Ancef if at all possible. There's some newer data now saying that you can there's suggestion that we may be able to use linezolid as step-down therapy. That is still very, very, very controversial. And I would only recommend that as a last case, last line scenario. There's also a little bit of data now with our long-acting lipoglycopeptides. They're about $2,000 a shot, but they last for a week, so the patient would come in every 2 weeks, every week for administration. There's more data with ceftaroline than there is with linezolid and the long-acting agents, but it's still administered twice a day, so we really would prefer to use vanco or dapto in our MRSA bacteremia cases. Do not use Clenda, which your patient failed
He died.
and died. Oral cephalosporins, you do not want to use oral beta-lactams. They have very poor serum concentrations. Clindamycin, your tetracyclines, so tetracycline, doxycycline, tigecycline, do not use those. And your fluoroquinolones. There's really either no data or data showing that they are inferior to our drugs of choice. So you're really limited, which is unfortunate since the Staph aureus is probably the most common in IV drug users. A lot of times they're stuck in the hospital for up to 6 weeks. Next slide, do you want to set it? So we'll go back to the case.
Let's go back. So, her comments about clinical presentations, you're going to, staff likes things that are not normal, like joints that are degenerated, anything that's not normal, the blood flow is not good. So you'll see all the time that these patients who have chronic back pain, they will come in, oh, I always have back pain, but it seems a little bit worse. And you do an MRI, and that's where they've infected the joint, they've infected the hip. So it's really important. You see Staph bacteremia and it's not clear, you ask about pain, because they will, you get in the neck. It really likes anything that's not normal in terms of vertebral body and joints and bones. And so it goes for where there's trouble. So let's go back and go back to the slide a few more times. All right. So we have his urine that was sterile on emission is now growing greater than 100,000 Staph aureus colonies. What do you make of that? Does he have a urinary tract infection as the source of this?
You guys can answer.
No.
Yeah, exactly. But I get phone calls from the community and say, oh, this patient has staph in his urine and now he's bacteremic. Is that? And they say we need to treat this staph bacteremia. It's not, okay. The bacteria, as I said, staph doesn't spontaneously cause urinary tract infection. It has to get there. So it's either through the blood and getting passed into the ureters, or it's through like somebody had a prostate biopsy or has a Foley more commonly. So if you have a nursing home patient who's got a chronic Foley and now a staph and bacteremia, then I would say yes, it's probably the source if there's no other source. But a healthy person who doesn't have a Foley, staph in the urine, 1 to 100 is that it's going to be hematogenously spread to them. Okay, so that's it just tells you that it's in the blood. So that should be very important. So next question. All right, so what's their diagnosis on this patient? What's the fancy term? This arm.
Phlebitis.
Well, he's got. You can feel the arm there, and the vein is thrombosed, and presumptively the staph was introduced to the PIV site, and so we call that a staph septic phlebitis. Okay, and those have to be watched carefully because if they don't get better or the bacterium persists, that's something you want to have your vascular surgeon take out that vein. Okay, and so this is most likely the source of this patient's infection. But again, it's the blood and the bacteria has gone from the arm throughout his system, and so even though we have a source, and you have to look at other sites of possible infection, particularly the heart, and instead it went to his urine too. So I would say the diagnosis would be staph septic phlebitis, and we've had conversations about with the infection control, how do we prevent this? But this is a relatively common thing. Do you take it out for 3 days using chlorhexidine patches and stuff like this? But we found this, and the nurse hadn't noticed it at all. So this was not a good thing. So next one. Okay. So is a UTI the source of this bacteremia? We just said no. It's secondary to the bacteremia. And so, does this patient require IV therapy for the bacteremia? What's always the answer?
Yes.
Yes, right. It's always check A. Yes. Okay. So, unfortunately, that's the one disease that must be treated IV at this point. You can have pyelonephritis with bacteremia. We put them on oral quinolone or Bactrim, and that's fine, as we talked about. But the one thing you do need is IV therapy for staph bacteremia. And what are the two big antibiotics that we usually start off with? If it's Staph aureus, what are the two ones you want to use? No, if it's regular Staph aureus, it'd be and
Fake.
cefazolin.
I didn't hear the other one. Cefazolin.
Yes. Yeah, so those are the two ones. If they have some allergies, then you might have to go with Vanco, but don't use anything static like clindamycin or quinolones or anything inside that. Okay, so that's very important. Cefazolin is only 3 times a day and extremely cheap. Nafcillin is unfortunately every 4 hours. So you can do some continuous infusions, and it is expensive and be hard to tolerate. But those are your drugs of choice, okay, for those two infections. So what additional tests should we do on this patient? Give me 4 or 5 things we'll want to do on him.
A TEE or a TTE.
Yeah, somebody else can barely hear that. That's bad. Oh, bad. Yeah, so I know that's bad. So we'll definitely want to do some cardiac evaluation. you listen to the heart. First of all, do you hear a heart murmur? And then if you hear a heart murmur, you probably want to go right to a transesophageal echo to evaluate that murmur. If you don't hear a murmur, you probably start off with a transthoracic echo. You know,
they generally recommend waiting a few days to get the TTE because it may take a while for that vegetation to develop where you can see it. So if there's not a murmur and immediate need for an echo, waiting a couple of days but it should absolutely be done.
The TTE is easy to order. The TEE, you may get, some irritated cardiologist said, I don't hear a murmur. Why are we doing this? You have a negative. I can read the TTE. So sometimes you just have to give in. All right. So what other tests do we want to do on this patient?
Repeat blood cultures.
Repeat blood cultures, okay? Definitely, okay? Continue doing that every 2 to 3 days. What else? Just caring for this patient, what would we want to do? So let's say his blood cultures are positive, again, 3 days later on this patient with the infected IV site. What would you want to do next?
Any thoughts out there, anyone? Unmute yourself or write in. Go ahead, Beth.
Yeah, remove, if he had a central line or a PIC, get that out.
Oh, I mean, they pulled out the PIC line, so hopefully he's
Okay.
advised to a peripheral IV. But he's still bacteremic. What would you do? Well, source control, remember?
Oh, yep.
Like, get that septic vein removed. Sometimes he's getting persistent bacteremia. Like for our orthopedic guys, whenever the post-operative joint gets infected, the orthopedic guy always says, no, it's not infected. But, if they have persistent bacteremia, that joint needs to come out, okay? It needs to be washed out or something else like that. So any kind of thing where there's the bacteria can be hiding, or if it has back pain, he's still bacteremic, get that MRI. Does it need something drained? Okay, you've got to look really vigilantly. Listen to what the patient's saying. Oh, this hurts. Oh, I have a weakness or something like that, or I have a headache. You got to find that source. So, and a lot of people we have drug addicts who come in with abscesses, and make sure that abscess gets drained. Okay, so for this patient, if he's still bacteremic and he's still febrile, I would definitely ask your vascular surgeon or general surgeon to please consider removing the vein as the source. If he's an orthopedic guy, I would say, let's wash out that joint and deal with it. Okay.
I think Kara, did you have another comment?
No, I was just going to say culture the tip of the PIC line when we were talking about the PIC line. That's all.
You wouldn't put a PIC line in until the bacteremia resolves. So you probably do a peripheral IV in this guy until the bacteremia resolves.
But yeah, if he had a PIC line as the source, obviously he would absolutely want to send it as send it off for culture.
Yeah, or if you have a cancer patient who comes with Staph bacteremia, you probably want to pull out their portacath, their permacath, or something else like that. But again, Staph, as she says, it produces a biofilm. So it just loves to hide in joints, in prostheses, artificial heart valves, okay? And so how long would we treat this patient for? Let's say you start antibiotics, he has a negative transthoracic echo, he's afebrile, and the vein looks a lot better in 3 days.
I'd still go longer if there was an infected septic colitis. I'd probably go for
Probably 4 weeks, yeah.
Yeah, I was.
Yeah, extended. Yeah, so it makes things difficult. All right. And when can a PIC line be placed? You definitely, because it is plastic and the Staph can adhere to it, you want to not put a PIC line in until the bacteria is resolved. Cefazoline's nice because if we give it to a peripheral IV, and some hospitals can do those midlines, which are only about 10 inches long, which is much easier on the patient. But definitely, you'll want to not place a PIC until the bacteria is resolved.
The other thing is you want at least every 48-hour blood culture because your treatment starts at the first negative blood culture.
Right.
So if you wait too long, you're not sure how long to treat. So if you're going to treat for 2 weeks, it's 2 weeks after the blood culture.
Yeah, so this is also different. You know, you'll have an E. coli pyelonephritis bacteremia. I don't repeat blood cultures. You know, if their fever goes away, there's no need to repeat almost any kind of strep pneumonia. You don't have to repeat blood cultures. Patient's clinically doing well. There's no point to it. But the staph is the one thing where you actually want to document negative, okay? Because if you're wrong, you're going to mess things up. And
there is data that people with Staph aureus bacteremia, even just one bottle positive, do better with an infectious diseases consult, a formal ID consult. I know that's not always feasible, so it's really where the data is if you follow a structured approach to Staph aureus bacteremia, follow those 5 points, you're giving your patient the best chance of a positive outcome. And if you don't do that, you're increasing the risk to the patient significantly. So you really need to have a checklist when you go in and see these patients and when you treat them. If you don't have an ID consults helping you with the patient.
it also could be difficult if you're a hospitalist. You know, who's going to follow this patient when he gets out of the hospital? And oftentimes people have to end up in a nursing home, but who's still following? Or, you know, patients want to go home and you have to have somebody sign off and someone, the home nurse follows, because most people don't have private physicians anymore. They're in and out of the hospital. So that can be oftentimes, at the hospital I work over here, a regular physician cannot sign off on antibiotics. It has to be an infectious disease physician so that they can get a hold of somebody, because the hospital disappears after a week. And there are the smaller hospitals where, you know, you just have the hospitalist and the surgeon, and that can be a very difficult situation. So people oftentimes end up going to nursing homes where they could actually go home. So let's keep on going. All right. So just to review, we've talked about this in the past. What does it mean to be methicillin susceptible versus methicillin resistant? And on the right side there, drugs like penicillin, you can see what's called the peptidoglycan chain. This is basically the armor around the bacteria. It's on the outside of gram-positive organisms. And what it does is you have this like steel wall, and everything gets screwed together. And what happens is there are enzymes which, you know, screw everything together, they're actually called penicillin binding proteins. But basically they make the structure of the cell wall. And penicillins and cephalosporins bind to these enzymes and they inhibit it, so the cell wall is no longer structurally sound and the bacteria die off. And so bacteria have been around a few billion years, so they're not you know, dummies. And so so we have these penicillins coming called beta-lactam antibiotics, which is the structure of the penicillin cephalosporins. They're coming to try to bind and inhibit these enzymes. So the bacteria secrete something called beta-lactamase. Beta-lactamase is basically an enzyme that breaks open the cell, the penicillin structure, so it activates it. So so penicillin is destroyed by beta-lactamase, but we do have bacteria which are not affected by beta-lactamases. And those are drugs like oxacillin, methicillin, the cephalosporins, and drugs that have, for example, ampicillin plus a beta-lactamase inhibitor called Unicin. So when we have a bacteria that produces a beta-lactamase, we can't use penicillin, but we can use drugs which are not affected by beta-lactamases, such as oxacillin or methicillin. The beta-lactamase doesn't inhibit them, or cephalosporin. So that's what we call methicillin susceptible Staph aureus. The bacteria produces a beta-lactamase, but these drugs, cephalosporins, nafcillin, oxacillin, are not affected by them. When, however, the enzyme that produces the cell wall changes its shape so that that drugs like methicillin, oxacillin, nafcillin, cephalosporins can bind to it, now this enzyme is now resistant to these standard drugs. And we have to use a drug like vancomycin, which works on a different part of the cell wall production. So methicillin susceptible means it produces a beta-lactamase but doesn't affect it by it. Drugs like vancomycin are used for methicillin-resistant bacteria who produce an altered enzyme so that the methicillin can't bind. So that's really basically what we're talking about, MSSA. So if you look, I don't have glasses, but if you look at this report, what we see is, can you see penicillin resistant there? Can you guys see penicillin MIC resistant? So that means, what is that? What is the bacteria produces a beta-lactamase, right? So we know it's penicillin resistant. Very good. So if we go above it, oxacillin is the same as methicillin. It's oxacillin sensitive. So we knew that this Staph aureus produces the beta-lactamase, which destroys drugs like penicillin. But drugs like oxacillin, methicillin, cephalosporin are not affected by it. So we would call this methicillin susceptible Staph aureus, right? So we wouldn't need to use vancomycin in this situation. So we can, an ampicillin sulbactam is basically a stand-in you can think for cephalosporin. Ampicillin is like penicillin, it's destroyed by beta-lactamase, but the sulbactam inactivates it. So we see ampicillin sulbactam is susceptible. So basically, we know there's a beta-lactamase producing Staph aureus, susceptible oxacillin, methicillin, but it's not resistant to drugs like the cephalosporins. So we would use, what drug would we use for this patient? What could we use?
Steve, you want to unmute yourself? Or go ahead now.
Yeah, I was going to say we could do the Ancef Q8.
Perfect, yes, exactly. So if we saw oxacillin resistant or ampicillin resistant, we would know that this Staph aureus is not affected because it has a mutated enzyme, so we'd have to use vancomycin, okay? And just for, particularly since you're in orthopedics, I see a lot of old people that have Staph bacteremia and they can't take their prosthetic joints out because they couldn't survive surgery. And oftentimes you go in there, wash it out, but you can, unless everything's completely removed, you oftentimes will have a biofilm. So I might treat a patient like that for 4 to 6 weeks of cefazolin, but then I would switch them to a drug like tetracycline, doxycycline, and just leave them on that for the rest of their life to sort of suppress the staph. And that's been very effective. Doxycycline is very effective. Bactrim is very effective. But once you resolve the bacteremia, but somebody has, they can't have their hip removed, they can't have their prosthetic heart valve removed, they're just not good candidates. Definitely, I think that's a very good thing to do, but you wouldn't want to use doxycycline up front because it's not going to kill the bacteria initially. And so that's something to think about because, a lot of our patients are older and they get a staph infection and they can't go through that whole two-step procedure because it's just too risky that they'll treat the bacteremia and then we'll put them on a drug like doxycycline. So
you want to initially start with the cidal agent?
Yes.
So is ampicillin sulbactam an option there?
Yeah, it's on the top.
I'm just,
Oh, are you
we're
asking?
treating the staph bacteremia. I was asking the audience. So you wouldn't use ampicillin sulbactam for that.
Yeah.
It's always use your mainline antibiotics.
Yes.
Always.
Cefazolin, nafcillin, and vanco for your MRSA, or Dapto, or Dapto would be another option. Okay, but just, I think the whole point of this talk is find the source, treat aggressively, and look for hidden things, and listen to the patient where they have complaints, and then an extended course of IV therapy.
Suzanne, go ahead. Oh, I thought maybe you unmuted yourself with a question.
We've had a number of cases where a patient developed something post-surgery, a staph infection, and often the physician, if they put in a hip or something like that, they're reluctant to say that hip is infected. And they're also, I can remember one case where we had a patient that we had on daptomycin. We couldn't clear the bacteremia for a long time. This patient had a fluid collection. We kept asking the physician about the fluid collection. He goes, no, that's just seroma. It's not infected. Don't worry about it. We treated him with Dapto. We couldn't get it. We added ceftaroline to it. And we still couldn't get it. Finally, we ended up draining that fluid collection. It was infected. That was the source. And it was 6 weeks of messing around.
We don't mean to rag on surgeons, but
It can get frustrating, trust me.
Willem, go ahead.
Can you hear me?
Yep, go ahead.
Okay, so my big question is why wouldn't lab list cefazolin on this culture susceptibility range?
because basically, they're using oxacillin or methicillin as a stand-in for that whole class of drugs. Okay, because if it's oxacillin susceptible, it tells you it's not MRSA, so any drug will be effective that works against it. So, and so they don't even have to list Sulbactam. They could just, basically it's a stand-in for it.
But any mainline drug,
Any mainline.
it's got to be a mainline staph drug, like Ansef is.
Like they'll list only oxacillin, they do methicillin, nafcillin, so it's whatever, they're all called MRSA or MSSA, so.
And it just, I don't even know if cefazolin is the microscan panel that we have either. So we do a lot of education that if it's oxacillin sensitive, you can use cephalosporin, particularly first generation cephalosporin.
All right, good question. So for the new listeners, if you're always welcome to call us, okay? We don't bite. On the website, my phone number is available. And you can just text me and say, I have a question I want to ask you. Especially if like in a small hospital, you don't have any consults. And I get a lot of calls from small hospitals from people asking. So I'm more than happy to talk to you guys.
All right, that's the top of the hour, everyone. So thanks for joining us. We'll be back next month. September 19th is the date for that one. So hope to see you then. Thank you.